Okay, here we go. Good evening, everybody. Welcome to another episode of Mondays with Moshe. This is Moshe Norman out of Lakewood, New Jersey, together with our featured guest tonight, Dr. Sandra Paulsen, who is a clinical psychologist out in Washington. Now, let's not get confused between Washington, where all the excitement is happening. Sandra is actually in Washington, where there is nothing happening.
Nothing's happening at all.
In the forest, on an island. It's just her and the trees and whoever comes for treatment, right? Or
That's
something.
right.
Any pets?
Yes, I had two therapy dogs. One of them died a few weeks ago, and the other one's at home because she's grieving.
Okay. Okay. Well, thank you very much for joining us tonight and agreeing to join. I know there's so many people who have read your books, and I do want to say I forgot to tell you this before the show, so we're going to do it live. But there was like a lot of excitement when I announced that you are going to be featured tonight. Can you tell me why? What is it that you shared or you contributed to this field that elicited such feedback?
Well, it's something of a mystery to me. I know that, well, my best answer is that people really like my books because they meet the reader about 80% of the way. I have not only written text, and I'm a reasonably clear writer, but people really like the cartoons. I illustrate my books with cartoons, oodles and oodles of cartoons that quickly convey psychological concepts. And people tend to use those cartoons with their own clients sometimes. And so I think that's my claim to fame in part. But the other thing was that for those of you who are EMDR informed, I was the first one that said to Francine Shapiro, who was the originator of EMDR back in 92 or 91, I started getting her attention and saying that EMDR is a divining rod for dissociation. And initially she didn't want to hear it because she wanted to get EMDR accepted in the universities. And she thought that dissociation was way too woo-woo. It sounded like hypnosis and she wanted nothing to do with it. She wanted a cognitive behavioral. And I persisted like some kind of Paul Revere. And then I wrote, my first book was about that, this one. And it's an ego state therapy book for working with parts of self in a way to use EMDR safely. And that was where I put my flag in the, what's that expression? Flag in the sand? Something like that. And people really needed that information to avoid doing harm. People were doing a lot of harm. And they still are if they don't know how to deal with dissociation. So I think those two are the two big things.
Okay, fair enough. Thumbs up if you read one of Sandra's books, and if the reason that she's giving is adequate, or is there really more to it that she's being humble about? Okay, so I do want to begin, as I do every week, just mentioning our sponsors, and I'd love to see some thumbs up if you took a look yet at officestreamline.com, which is the virtual secretary that you can hire so that you can save a couple of hours a week of work and be able to spend those hours doing what you love, which is the clinical work. So if you took a look at officestreamline.com, give me a thumbs up and let me know that you took a look at their website. And of course, OKclarity.com, which is a site that will host your website so that you could promote yourself and your work, your clinical work, your group work, your lectures. They will promote it for you. All you have to do is sign up for membership and they'll take care of all the details for you. So take a look at OKclarity.com. Tonight's topic, Sandra, is the topic of preverbal trauma. It's actually the topic of treating preverbal trauma through EMDR and perhaps other modalities or other forms of therapy. But I think we'd be remiss if we don't begin by talking about the concept of preverbal trauma. And I think the real question that I have is, I mean, how could a person really have trauma before they actually have anything developed in their mind? You have a little infant who's developing just in the early space of their attachment, and their mind knows nothing. It's a blank slate. Now, technically, if we keep that baby blank for 3 years or 4 years or 5 years, and then begin to develop the brain, right, and develop the mind and develop the implicit memory or explicit memory, they start just 5 years later. So if you have a child who's preverbal, whose mind is really not developed at all, how is it possible for there to be trauma?
Well, we're hardwired for several things. And here I'm referring to Panksepp's understanding of the brain. He's the father of affective neuroscience. And he talked about a lot of things, but one of the things he talked about is we're born with emotional circuits. They're hardwired, they require no learning, they're present from birth. And we have seven, at least he found 7 basic affects: rage, fear, lust, care, panic, which means separation panic, seeking, and play are hardwired in the animals he was researching with. And he was not doing brain experimentation on humans, it was on rats and other mammals. And then on top of that, immediately we start our object relations learning in the I and thou of the intersubjective relationship with the primary caretaker, who's usually mother, not necessarily. Mothers, Jaak Panksepp would say, in the animals he was studying, have a stronger care circuit. Usually the females have a stronger care circuit than the males. Wouldn't have to be so, but it's often so. And it makes sense. I mean, in terms of evolution. So that object relations learning starts from the beginning, and you don't need to remember it, but the body keeps the score, as Bessel van der Kolk famously said. And when people talk about, I've been depressed all my life or anxious all my life, or we know that they've had a personality disorder that seems to go all the way back, right there, it's archaeological evidence of early learning. And then Panksepp's third layer. So there's the subcortical affective circuits as layer 1, the object relations learning, or Alan Shore calls it relationship templates, to avoid the object relations language, is level 2. And then level 3 is everything else that we learn about emotions. So if we learn mindfulness, if we learn the names for emotions, if we learn all kinds of stuff, that's layer 3. But it's in the object relations layer that people learn all sorts of important things that are going to affect them for the rest of their life. I feel like I'm preaching to the choir here, but the ability to downregulate is born, according to Alan Shore, in that I and thou in the first years of life. Doesn't matter that people can't remember it, but the body does keep the score. And when we get around to talking about treatment, it's really been fascinating to see how true that is. We can turn things around when we test that hypothesis that we can hear baby's untold story and repair it in imagination, which is, I'll just wave this book while I'm thinking about it. This book, When There Are No Words, Repairing Early Trauma and Neglect in the Attachment Period. It's all about hearing baby's story, but I'm getting ahead of myself, aren't I?
Yeah, can we slow down? Let's dumb down a little bit some of the things that were mentioned so far. First of all, talk to us about subcortical and object relation stages of learning or of development and attachment. How can that be affected? What does that even mean? And how could that be affected adversely?
Well, the affective circuits aren't learned. That's the whole point. That's the hardwired, that's the motherboard, so to speak. You're born with it. And then you put the apps on top of it. The learning happens on top of the circuits. So, babies have the ability to go emotionally from 0 to 120 miles an hour in 6 seconds because they don't have the capacity to downregulate. So that would be, say, the rage circuit or the fear circuit, fully engaged, but with no brakes. So they're all accelerated, no brakes. The brakes are acquired in the early learning in mom's loving arms or not.
So wait, so when you talk about down regulating, just so that to make sure everybody understands what you mean, are you referring to the ability to basically slow down and regulate their emotions? So the way I heard
self-soothing.
Yeah, the way I heard it recently is that babies, when infants have emotions, the emotions are extremely intense. And that is because there's no context for them to sort of know that it's not going to end the world, or the world won't end when they feel scared, fear, or whatever feeling it may be. And they need that external soothing and calming from, as we stereotypically or call it, from the mother. And that will start to teach them or develop this capacity that something bad can happen. I can be afraid and it passes through mother's.
Yes. They learn that emotions have a crescendo, and then with comfort, a decrescendo. So they learn that decrescendo is possible. And further, they learn that what to expect in relationships, that someone will be there or not be there. And
So
if no one is there, if they're left in a state of, for example, terror without comfort, then the only choice they have is dissociation, and they're going to truncate their emotions at the height of that crescendo. And so they never learn the decrescendo, and they never learn that you can count on others for mutual regulation, co-regulation.
Right. And so that they can't, if they were able to, then they'll be able to self-regulate because they learned that this has somewhere to go.
Right.
There.
Right.
Well, the way I sometimes actually use the same hand motion, I used to tease myself that I use this very sophisticated hand motion to teach this concept. But I think that, what would be reasonable to describe is it begins like this. And then ultimately, after 1,000 such interactions, the crescendo begins to lower, and it's this hardly little curve of, oh, that didn't feel good, and then get over it.
And then the other thing mentioned there, and it's really important, is many people have developed whole defensive systems to protect against re-experiencing annihilation terror. And annihilation terror is what happens when a very tiny baby who has no structure to the self is left unattended with, or worse, with a frightening caregiver, and but they don't have the structure to contain it. So there's just terror, no up, no down. There's nothing in their world but an infinite sea of terror. And the same trauma or neglect years later, when they have a self, wouldn't turn into the same kind of annihilation terror. It's because they're so little when it happens. So we may have occasion to get back to that when we talk about treatment.
Yes, I would like to actually. The question I think that's really bugging me on, when it comes to that, is that when these things happen at such a young age, and then we sit in therapy with them, they can't ever identify because they have no memory of it. It's only in their implicit memory and not in their explicit memory. And so then how do we treat it? But let's put that on hold until later and keep everybody in suspense. And force you to have some self-control, I guess, right? Okay, got it. I picked up on the biting the finger. Okay, so one of the things that struck out at me at this last comment that you just made was the idea that babies or infants who are left for long periods of time in neglect or in terror. And first of all, you talked about the crescendo and then going down and that leading to dissociation if there's no down regulating. But what about suppression? What about learning to push it back the other way? Is that
that's certainly
coping mechanism?
That's absolutely one of the ways it can go with, because the mechanism for dissociation is the use of the body's own endogenous opioids. So if you were a gazelle out on the African savannah and you'd been outrunning the lion or trying to, but now you're about to be had for lunch because you're weakened and exhausted, in the last moments before you were toast, you'd be washed with endogenous opioids, so the pain isn't so great. And that's what happens certainly with big T traumas in humans. But when a child is neglected, it's also a device available to numb the terrible pain of not getting what we're hardwired to get, which is nurturance and love and containment and the loving arms, the physicality of embrace. If that is all absent, the child has not much choice because they're utterly helpless, except to use endogenous opioids, and that can produce somebody who's somatically dissociative or alexithymic, even if they're not structurally dissociative or DID.
So you're oh wow, that's fascinating. Well, let me just make sure I understood that. You're describing symptoms of people in their later years that resulted from the formative necessity to dissociate. And you're saying that that will play itself out in not only let's call it cognitive dissociation, but also let's say somatic dissociation, where they will lose their feelings, I guess a kind of numbness, not have feelings on some level because they needed to dissociate in order to save themselves from pain.
That's right. It's a survival strategy that here's a cartoon on point. Let's see if I can show it to you. The baby has no choice but to sign mom's contract, no matter what the fine print says. And so the one up front is what our Dutch colleagues call the apparently normal personality. And in the back, I don't know if you saw in the back, there was one with dotted lines who's invisible, unseen, unheard, that holds the true needs and the true needs and feelings of the child that had to be jettisoned to get with the program, to sign on the dotted line. Because the child's because attachment's the prime directive, so the child's gonna make the best out of whatever pickles they've got.
Wow.
They kick themselves to the curb.
Okay. I just want to encourage everybody, if you have questions, so please raise your hand using the raise hand tool on the bottom of your screen. And ask a question. And
sorry.
It's hard to see that. There we go.
It's the child having to jettison their own needs and feelings to survive.
Sandra, who drew your cartoons?
You're looking at her.
No kidding.
No kidding.
You drew those all yourself?
I did.
Cool. Okay, let's take a question from a different Moshe. Go ahead.
Hi, Sandra.
Hi.
Thank you so much for, I recently read When There Are No Words, as well as We're Listening Body. And I model a lot of my work after your writings. I did today the affect resetting procedures for a client with an undiagnosed narcissism. Of course, I didn't say anything to the client, but shame is at the core of it. Regarding the topic of the somatic dissociation, lots of people ask me about using the naltrexone, the psilocybin, the psychedelics. I want to hear your thoughts on that if I can.
Oh, the only one I know anything about is naltrexone.
Right.
My colleagues, well, we co-edited this book. It's the only scholarly book that I've done or will ever do because I like making cartoons in them. But Ulrich Lanius and Frank Corrigan, my co-editors for this one, turned me on to low-dose naltrexone, which is an opioid antagonist. So when people acquired that tendency to somatic dissociation as a habit to cope with those unmet needs and terrible pain of not being nurtured or loved or seen, they have a habitual reliance on somatic dissociation and endogenous, the body's opioids. So low-dose naltrexone, which is generally under 4.5 milligrams, not that I'm a prescriber, I'm not, produces an effect not found at the higher doses used for alcohol and drug addiction, where it blocks those endogenous opioids and the person can begin to feel. There's no other effect of it. Like when they go on it, they don't start reporting, gadzooks, it's a miracle, I can feel. Every once in a while, somebody says something like, it's changed me, but mostly it's only when we start doing the work, they can suddenly, for the first time, discern the nuances of emotions and body sensations where they were previously alexithymic. It's quite remarkable. They may not be able to find the words. I always say it's like if you clip your dashboard wires and all your life you've driven your car without reading the gauges, then if a mechanic hooked up the wires, your dashboard would be lit up, but it would still be a while before you could learn how to read what the gauges say. So they can't necessarily say, oh, I'm feeling melancholy, but they'll say there's something right here. Whoops, you can't see, I'm pointing at my heart.
Thank you. The challenge is finding psychiatrists who are willing to prescribe the naltrexone.
Well, I work with telehealth NP because I work with clients that fly in from all over the country. Telehealth NP for nurse practitioner. I work with a Dr. Ann Yoder. She's a prescribing nurse practitioner. She knows how I use it. She's read the literature, and she is licensed to prescribe in most states. So it's worth checking and see telehealthnp.com.
Okay. Sandra, one of the things that struck me as you were talking about children of neglect is there seems to be an old school sleep training method, which is very simple and very old school. And it's the training method of let the kid cry it out. And if they spend 3 days, or I should say 3 nights crying it out, they'll figure out how to fall asleep. What can you tell me about that in terms of the potential risks and effects of implicit memory trauma that can happen?
Well, I think if those parents were loving, attentive, attuned the rest of the hours of the day, it might turn out okay. I don't really know. But what I see, I've never had anybody report that exact thing, although some people talk about Dr. Spock, being raised with the Dr. Spock tactics. But what typically the problem comes when it's an enduring day and night problem where the child is unseen, the child's needs are not met, they feel invisible. And so they have developmental arrests for each milestone where they were neglected, and they accumulate. It's almost, I mean, when we do the archaeological dig, which we'll get to later, that was a metaphor, we see at each milestone, you can see the artifacts of the neglect and the trauma. It's quite interesting.
So you're saying that it's potentially possible for a child to get TLC the entire day, but if his parents leave him at night to cry and scream for an hour straight for 3-4 nights in a row, that will not potentially cause damage?
I didn't mean to say that exactly. I meant to say, I don't know. I haven't heard that reported exactly, but it seems to me possible that whatever injuries might result from that would be less if the parents were loving and attentive during the day. But I don't know. I don't even work with kids. What do I know? I work with adults, and I've never had
manifest in adults too. The repercussions would manifest in adults.
I've never had an adult report that they were loved during the day, neglected at night. So I don't know.
Okay, so here, you're talking about reporting, and this is a question I see Aaron is asking it in the chat, and it's a question that I have also. There's 2 parts to the question. There's the old million-year-old question of nature versus nurture, right? Which you're always going to have people argue that that every child is born with a temperament, with certain nature, and how can we ascertain or even speculate that the reason that people behave the way they do or dissociate or split the way they do is a nurture issue and not a nature issue? That's part 1 to the question. It's the simple question. But the other part of the question, which is what Aaron's alluding to, is again, if this is pre-verbal trauma, sometimes you'll have clients or patients who come in and say, I know because my mom told me, I know because I was left at the train station, I know because my aunts and uncles told me that that's how I was treated. I was abused. I was neglected.
Mhm.
But very
Mhm.
often, some of these things were unreported,
Mhm.
and just simply unknown. And
That's
so,
right.
in the course of therapy, how could we possibly know, and must we know that there was a history here, an archaeological history that has roots in this entire presentation of the person, or can we treat it without knowing?
Well, to the first part of your question, I'd say, well, it's over my pay grade to know how much is nature and how much is nurture, except if their symptoms remit after treatment, then we can claim it as our own.
Hmm.
And if on follow-up, the symptoms are still remitted and they say, thank you so much, my relationships are better, I'm much calmer than I'd been ever in my life, et cetera, that's, I don't
Proof is
need
in the
a
pudding.
micrometer to measure that. Sorry?
I said the proof is in the pudding.
The proof is in the pudding. I forgot the second part of your question.
The second part was about must we know? Can we always know when things were unreported? And
Yeah.
maybe the same answer. But go ahead.
So what I always tell people is, because it's very common for people to come in anxious because they say, I know I'm here to do early trauma repair, but I don't remember anything. And I say,
Correct.
no worries,
Correct.
because it's not in explicit memory with picture and narrative. If it's available at all, it's in implicit memory, which is much more nuanced. I call it dust bunnies. I got a cartoon for that, but I'll never find it. Guy looking under the bed trying to discern dust bunnies, and because that's how nuanced it is. It's shapeless, it's ephemeral. But I do have something at hand that will help this conversation. See if I can get you to see it. The story tells itself in these myriad channels. So you'll see there's several channels. I'll read it to you in a second. That they're puzzle pieces that come together. So when we, I'm about to talk about treatment. Maybe I should save this until we get to treatment.
Okay.
Or is it?
It's not a
Or is it?
sin. It's not a
It's
sin.
not?
No.
Okay. All right. So there's the client's narrative. That is what they've been told. Maybe they read their medical records. Maybe they read the obituary of the sibling that died, and so forth. There's also the client's affect and soma, made more available if they are on low dose naltrexone. There's also what you can observe them behaviorally enacting in the room, or that you know about what they do behaviorally in their life. There's also what's get enacted internally between parts, because those abuse and neglect dynamics tend to be reenacted internally between parts of self, even in a non-structurally dissociative individual, non-DID individual. The story tells itself in therapist mirror neurons. When I'm sitting here and my client is 7 feet away across the room on the love seat over there, and if they're having stuff happen in their body, even if it doesn't register in their conscious mind because of a lifetime of alexithymia, I can very often, and I bet many of you can too, it's not magic, it's not Houdini, I can discern in my body, in my mirror neurons, what's happening in their body. And if I make inquiry about it, it's usually supported either immediately or in a couple minutes. Like sometimes they'll say, I don't know what you mean. And then 2 minutes later, they're sobbing when I had felt a burden on the heart. So therapist mirror neurons, also what's in the therapist intuition, or what's in the energy field in the room. And that's, speaking of woo-woo, that's maybe some of you have this too, but I see words in old-fashioned typewriter font, and if I just have the courage to read it, it applies almost always. Or I'll see pictures that don't make sense to me, but it makes sense to the client. And but also in terms of the energy field, if there's an energetic holding, that's what I feel in my mirror neurons. If there's an energetic release during the EMDR, I feel it as a directional wave. I don't know what law of physics this is, but it hits my, if I'm sitting facing the client, I feel it on my legs first and then on my chest. So I get sort of sprayed with whatever they're releasing. I know it sounds weird, but it happens all the time. And then finally, that which gets reenacted in the relationship field. So each of these channels of information provides a puzzle piece. And I work in the intensive format all day for 3 days. That's almost always what I do now. I don't do any conventional therapy
Just to
anymore.
clarify so that the group understands what you're saying. You actually sit for how many hours a day with one client?
6 hours with structured breaks
And you do that for 3 days.
for 3 days, and then they fly home to Texas or wherever they came from, or London or New Jersey.
Wow.
So, and I really like that, because when you're dealing in all these nuanced channels of information, it's much easier to keep track of the threads than in a 45-minute session. I don't know about you, but I just forget everything. If I'm with somebody briefly and they leave and somebody else comes in, I have a hard time retaining it, especially as I was aging. Not that I'm aging, but on the assumption that I'll eventually age. I'm 71 actually, but
Yes, Sandra, yes, you probably will forget the things that your patients told you when you were 41, when you're 70.
So it's just much more comfortable way to work for me. Plus, I'm on the autism spectrum, not very far, but I'm on it. And it's much more comfortable for me to just do a deep dive in and palpate their brain in this deep way for 3 days, and without interruption except what I impose by
So
my breaks.
I think you were describing to me before the show your capacity for immersion,
Yeah.
very, very strong. And so for you to immerse yourself into the patient's space for 3 days works a whole lot better than to see them twice a week or once a week.
Yes. The stress for me and for many people who are on the spectrum somewhere, I think having to change the interruptions and changing gears all the time is so stressful and even overwhelming, that this is a much better way to work. It utilizes my capacities and gifts better than the other. So I forgot where we were, but
That's where we were, where we are right now.
very
Okay.
good.
So one last question before we talk about treatment, and I don't know if you can explain this, but in utero trauma, I know there's talk about in utero trauma. Can you explain at all how a person who isn't even born yet and is just a fetus can have trauma?
Well, let me pick the most vivid examples, because I never know. And well, actually, it's impossible to do this, to talk about this without talking about treatment. But what I've learned doing treatment.
Go ahead. If you do treatment, you could talk about treatment.
Yeah. When we do the early trauma approach, we're targeting time periods, not a picture memory. So with standard EMDR, we're targeting the fiery car crash and the narrative about the fiery car crash at age 35 or whatever. But when we're doing the early trauma approach, there's no picture memory. There may be no narrative except what you've been told, and that may or may not be true. Time periods, and we begin before the beginning, which is to say, where do you figure you were, if anywhere, before you were conceived? And people answer from their religious frame of reference, or what frame of reference, or from their atheism, or however they answer. Is that comfortable or uncomfortable? And if it's comfortable, then we strengthen that, make it vivid, and then we start going on. What do you know about your conception? Not the gory details, but how old were your parents? Were they married? Did they intend to conceive you? Is that comfortable or not comfortable? And very often people say, I was an accident. I ruined my mother's life. She would have been a contender. And it's all my fault. and so forth. To which I love to say, oh, you're the one that got her pregnant. But so when in the first months of gestation, it tends to be entirely cognitive because they're not going to remember being a divided cell. Although some seem to. I mean, they report that they do, but I maintain, what do you call that? That stance, willful suspension of disbelief. That's what I do. And I always tell them, we don't know if this is, this isn't evidence that's going to hold up in court or,
Right.
or we're
Preverbal
not going to
memory.
have any kind of proof of this, but we don't care about what's actually true. We care about what's emotionally true.
Right.
And how does it feel? What do you notice in your body when you think about the fact you were in an accident? Is it comfortable or uncomfortable? And they go, usually they'll say uncomfortable. Every once in a while they'll say, I don't care, but they care.
So the way you're tapping into their implicit memory essentially is through their feelings.
Absolutely, yeah. Well,
because what you know is what you feel is what you know.
Well, remember on this thing, that was one of the channels is the affect and soma. The clients report if they scan their body, and this is where if they can't feel anything in their body, we're dead in the water. It's like pulling hen's teeth for 3 days. I hate it. But which is why at the intake I get, which I may do by telehealth, make sure I know that they can discern and get them on naltrexone if need be. But yeah, so they're scanning their body and they go, it's a little uncomfortable. Not very, they say, minimizing it. In this business, any nuance, any dust bunny is what we need, because we're listening to hear the untold, unheard story of that invisible baby, not the one that signed on the dotted line and had to tap dance according to the terms of the contract, but rather the one whose story was never heard, whose needs and feelings went unseen. And after a lifetime of pushing that away, they give me some resistance, as you can imagine. So on Wednesday, which is day 1, I ever so sweetly point out that we need to hear that story, show them some cartoons. Thursday, I start getting more pointed. By Friday, I say, how long are you going to keep kicking that kid to the curb? And I show them the cartoon of somebody pushing away their child's self while they're going blather, blather, blather. So where were we? Oh, gestation. As you move along in gestation, it's more likely for a few people that they'll have something that they become aware of that seems real and true to them. And I've had several times, I've had people jump involuntarily in about second or third trimester and they say with alarm, I think he kicked her, or something like that. I never know if it's true. But as we're listening to the story within a time period, and I just moved ahead in gestation, but we wouldn't do that in the treatment. We stay in the time period we're listening to, and it's kind of a forced march. I keep them in the time period that they're in until we've repaired it. After we've heard baby's unheard story, then we repair it in imagination by making provision, usually of ideal parents. And I forgot to say, originally this protocol was developed by Katie O'Shea, and she brought me in collaboratively because I was known for my work with dissociative cases and collaborated for some years. We were going to write the book together, but she didn't have time. So I ended up writing the whole book. But
Sandra, I just want to make sure I'm following this. Are you talking? Are you talking about when you work with a patient? Are you starting from their gestation story, from
conception,
conception, all the way through all 3 trimesters, through childbirth, maybe even the childbirth itself, and through formative years? Is that the journey that you're taking them through?
Yes, we go depending on what we know about the story. We go approximately, conception, first trimester, second, third, birth, then the first weeks after birth, then to 3 months, 3 to 6, 6 to 9. But if you know there's a lot of, hospitalizations and surgeries, then you target those
You're gonna
time
target what
periods
you know.
smaller.
But you said you even actually target preconception. If this,
Yeah, we start, and I learned that lesson the hard way because I worked with somebody who had been conceived in rape, and her mother had hated her whole life because she looked like the rapist. And we were looping and looping, which is EMDR parlance for when it's stuck and you can't get resolution. And it was only when I went back to where do you figure you were before you were conceived that she had a beatific look come over her face, and she said, well, I was in God's heart. And she sobbed and sobbed wonderfully. And then when we resumed her conception story, it looked and felt totally different to her. So that's why I start preconception.
fascinating, fascinating. Okay, so then and so in treatment, the way you're walking this through is by tapping into their implicit memory.
That's right.
And how do you touch the implicit memory?
Well, those channels that I mentioned, the one I rely on the most is what they report from their emotions and body sensations. And if there's a discrepancy between my mirror neurons and what they're reporting, I'll have them check and see if what I'm noticing might be true.
So show me what that looks like for a minute. I mean, let's talk about 3 to 6 months, right? So how would you explore the 3 to 6 month period? What would you ask them? What would you have them do?
Oh, I start out for most people, unless some mental health professionals don't need it, and most of my clients are mental health professionals, but I'll say what typical milestones are. I'll say a baby this age is getting more motor control and they're hell-bent on evoking smiles in mothers, and they're squealing with delight, and they still want to cuddle all the time. They're beginning to be able to control a little bit in their hands. By 6 months, perhaps they can roll over or sit up by themselves. They're beginning to understand some language, but they're not particularly using language. If they're saying anything, it's gibberish. And I always say there's variability. Knowing your mother as you do, I might say it this way if I think we're only cognitive. I might say, how do you think she'd do with that? Or knowing your parents as you do. But sometimes I'll say, and what I hope for is that if I say, what do you notice in your body in this moment as I'm saying this? And they often will say, I'm sad. Or there's tension or something else, they'll describe something bodily and notice that. And then I'll reflect back what I'm hearing. I'm hearing that for this time period where baby's hell bent on evoking a smile in mom, there's some sorrow there or sadness. Am I hearing that right? Then they will often say yes. And then the next thing we do is repair it by saying, what would you have needed to have it be on your terms, the way you needed it to be? Well, for mom to not have gone back to work and leave me with the babysitter, or not leave me with my psychotic aunt, or whatever the solution was at the time that caused the problem. So imagine it. And usually we use imaginary parents, mythic ideal parents. Not that they have no flaws, but they make repairs, which is what makes them ideal. And imagine getting all that you needed on your terms. And I make sure that they're experiencing it subjectively. It's not enough to see it for some baby over there. It's got to be the felt sense of it. And we linger with that until it's vivid. And then we go back and check that time period and check it again. And see, every time we go in, it's like panning for gold, very much like panning for gold, because you don't know, what you're looking for, but you don't know where it is. And so you sift and it's nuanced, and then you find it, and it's a gem. And then you repair it on their terms. And the really impoverished ones emotionally may not be able to even say what they would have needed. Like, I've got a cartoon for a guy that says, I don't need much, just a dry crust of bread. They're so used to neglect. And in imagination, we can live it up. We can lavish wonderful. If they want to multitude of heavenly hosts, they got it. You know, we can, they're trumpets and fanfare if that's what they need.
They could go all out in their imagination, and it
That's
helps
right.
develop their sense of entitlement, their sense of self-value, etc.
Mhm. And we don't go on to the next time period until the prior time period's been completely heard and repaired.
I see.
And then and only then we go on. There are
You talked
exceptions to
about
that.
matching mirror neurons, so I imagine that you're paying a lot of affective attention or uh, um, emotional attention to how the client is saying what they're saying, or how the patient is saying what they're saying, and if you see them getting excited and happy, or versus if you see them getting
Mhm,
numb or sad, you're going to pay a lot of attention to that
mhm.
and note that.
Yeah, we put it in words. We make sure it's in words because part of what EMDR always does is integrate the hemispheres. So we have all this affect that's been neglected over in the right hemisphere, where trauma, relationship, affect is stored, attachment is stored. According to Shore, it's right hemisphere to right hemisphere attunement. And we want to make sure that they end up with a narrative as well. And so that comes out of piecing together the puzzle pieces. And one of the things I do at the end of each day is say, how would you put in words what we did today? And then they start piecing together a narrative. I was a neglected child. I deserved love, they might say, for the first time in their life. It wasn't my fault. I was innocent, that kind of thing. Those are positive cognitions that come naturally out of any EMDR process, but certainly out of the early trauma approach. It's almost always about love and belonging and having one's humanity seen and honored.
Wow. So where does the EMDR part come in? Because you're talking about a process in which you sort of go through step by step their development, and you have them kind of relive that on a more from a more implicit place. And
Yes.
yeah.
So standard EMDR, when unmodified, involves a picture and a narrative of an event in explicit memory. Here, the target of the EMDR is a time period. And we process everything that I just said would be with bilateral stim going. Not continuously. I stop between sets to ask, what are you aware of? Just the way we do in EMDR. So it's very much mindfully in a moment to moment way. We're processing through. It's not heady. If they're intellectualizing, if it's all cognitive, then I have to bust them down to the felt sense level.
Mhm.
That sounded violent. I'm gentle about it.
You're gentle with your violence. I got it. Okay, let's take a question from Gregory. Greg, go ahead.
Thank you, Moisha, and thank you, Dr. Paulsen.
My pleasure.
I appreciate your good humor threaded throughout all of your insights and observations.
Thank you.
I'm curious if you can speak to, so just I want to make sure that I'm jotting down little gold nuggets here and there that are very meaningful to me. I always relate to my work as that I'm my first client, I'm always tending to my own consciousness in different ways, and then working with folks and in service, holding a safe container, but always coming back to working with my own edges and so on. And so there's a lot of little things you've shared where, oh yeah, that's good. That's valuable. So on a personal note, thank you. And on both a personal note and a professional service oriented note, I want to make sure I'm tracking with you relative to certain moments in what you've shared in the process, and one of which was when you were sharing about exploring at some stage, 8 months old or whatever that particular stage is, and there's a sense of feeling alone or sad, and when a client is giving voice or describing their experience, are they speaking in as a narrative at that point, or are they speaking, for example, a la voice dialogue or IFS, giving voice in present tense to, like giving the part of voice, it sounds like there may be a mix of narrative description of, so that period was like this, like at the end of a day upon reflection. But the way I heard it was that maybe in the moment to moment, there may be actual giving voice to the part. And I just didn't want to be presumptuous.
Yeah, the way it works, and I operate as an ego state therapist, which is a cousin to IFS. It's older than IFS, and I'm not really fond of ISS for reasons I won't go into now, but I could be wrong about it. But as an ego state therapist, the way I conceptualize it, and I've got cartoons for this, which I won't be able to find, but I see the adult client sitting on the love seat and the invisible unheard child adjacent, that the one that the apparently normal part had to push away when they had to jettison their needs and feelings. And that's the locus of the injury. And so it's my job to be what I call I call it a fierce avocado, but it's actually a fierce advocate for that invisible child's unheard story. So as an ego state therapist, I've got two voices. I talk to the adult self, and I ask them to listen to the body so we can hear and sort of rescue, in a way, that invisible hurt child. And so they report what they notice in their body. And I'm always the first to say, little one, grown-ups listening now, we hear how sad it was. Am I hearing wrong or right? I'm happy to be wrong. And grown up, what are you getting? They listen inside, and then they say, you got it right. Notice little guy's sorrow. Tap, 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 tap. That was bilateral stim for those of you that's not hand flapping. That's bilateral stim.
Thank you. That was helpful and clarifying, and also moving. I feel like I just got a taste of a session.
Yeah, it's very much as I just described. As I just pantomimed or whatever. But I do want to say there's much more to it than I can possibly say in, whatever time we have. Which is why I wrote a book, and I have a 2-day workshop about it. There's a lot of vicissitudes to it.
Thank you so much.
Let's take a question from Aaron. Thank you, Aaron, for connecting us, Sandra and I. But go ahead, what's your question?
Hi, Sandra.
Hi.
Aaron.
There you are.
So my question is about, I had a client that called me last week. He went for psychedelic, and he had a strong feeling when he was 2 days old, someone very close to him sexually abused him. That's what came up in psychedelic, MDMA. So I'm wondering how you would treat it and how true you feel it is, or.
Oh, I never know what's true. I don't try. I'm not a detective. I just want symptom resolution. But it happens a lot in here that people will get to a particular time period. Their anxiety goes up as we approach the time period. We get there and they're starting to, sometimes I can discern in my body before they are either conscious or willing to report, but they're starting to have body sensations associated with one kind of trauma or another. And I ask them to notice what's happening in their body, but it happens a lot. I mean, I shouldn't say a lot. I don't encourage it, but if there's something like that that's happening that they're not sort of coping to or willing or able to talk about, I'll use an ego state maneuver and say, little guy is grown up hearing, or little one is grown up hearing what you need her to hear. And then the adult self might say, I don't want to go here. I don't want to, I'm seeing my father's face. I don't want to go here, or something like that. Or usually there's not a picture. And I always say, we never know what's true. You may or may not decide you know what's true. We're just going for symptom remission because I don't want to be leading at all. But I'm hearing that there's something happening. You're describing body sensations in the genitals and that you're frightened. Am I hearing that wrong or right? Happy to be wrong. You got it right. Notice that. And then usually within a period of time, they'll have some kind of either clarity or the symptoms remit and they feel lighter afterwards. So we may or may not ever get, get anything specific.
You mentioned at the beginning of the interview that therapists often do damage. They don't know how to treat dissociation. They do EMDR without working on dissociation. Could you explain that? How do therapists do damage?
Well, I'm going to say something unkind about talk therapy. That talk therapy.
I'm talking about EMDR.
Okay.
EMDR therapist.
Yes. Well, EMDR is capable of doing more harm than talk therapy because talk therapy goes much slower. So EMDR is a power tool. And so a therapist who does not know about dissociation can rip the person off for their only defense and cause amnesia barriers to collapse. So the person is flooded, dysregulated, and can't hold down a job or take care of their kids or whatever. So I've seen terrible things happen. So which is why for however many years now, 34 years, I've been on a campaign to make sure all EMDR therapists know enough about dissociation, somatic therapy, the early trauma approach, and ego state therapy. It's quite a bit.
How can I make sure not to do any damage when I do EMDR?
Well, you have to first know if the person is DID. Let's talk about dissociation as if it's a binary variable. It's not, it's a continuum, but DID is the case where there's amnesia barriers, big time. So you can embed screening questions in your intake interview, sneaky questions. You can also administer the MID. Or the DES has false negatives, so it's not very good, but it's good, but it's not a diagnostic instrument. And then the SCID-D is the gold standard, Marlene Steinberg, American Psychiatric Press. The DDIS is another way. So there's several instruments that you can use to see if somebody's highly dissociative. And if they are, you don't do EMDR right away. You work with the system. In particular, you need permission from the parts of self that are guarding the fortress. And the number one issue is loyalty to the aggressor. Perpetrator introjects are palpably alters that are keeping the secrets and will sabotage the therapy because of loyalty to the aggressor. So you really want to do ego state work to work with those parts first before you attempt EMDR. That's what this book is about, is how to do that with dissociation. I've got another 2-day workshop about that. My workshops are at the sfrankelgroup.com. And there's something called the NEST bundle, neuroaffective embodied self-therapy, that integrates all 4 of these therapies that I'm talking about. It's 5 really. And that NEST bundle is on the Steve Frankel group. It was a year-long series I did once, but there's no book
Okay,
to support.
let's take our next question. Dr. Elliot Kaplan. Go ahead, Elliot.
Yeah, hi. Yeah, thank you. Thank you for coming on.
My pleasure.
As I'm listening, what I realize is that you're extremely present when you're with your client. And you mentioned that you're in your body and that you feel things in your body even before the client may. So I'm in my mind, I'm saying that you're kind of like a tuning fork in a way
Yeah.
with that client.
A Stradivarius.
Uh, okay, a strategy. Okay, that's even more complicated than a tuning fork. um, but I guess what I'm also hearing is that and I guess my question is, how much do you yourself focus on the therapeutic alliance that you're creating with the client? There's a conscious thing on your end.
Well, remember, I'm working rather surgically. I don't do any conventional therapy where they come in every week and we develop a therapeutic alliance. I see them for 3 days. Like a surgeon, you know, you see them and then you're done. You don't camp out and live forever in the surgeon's waiting room. So what I do, it's kind of instead of an ongoing relationship, I'm on the lunatic fringe of attunement in the way that you mentioned, but I'm also, I think by nature of how I come to the work, I'm really authentic and they know it. They know it. I don't know. I kind of think it's the autism. People can tell I come to it with an open heart and they're willing to work.
What do you mean
And
by autism?
What?
Did you say autism?
Yeah, I'm a little autistic. I disclosed that earlier. Yeah.
Oh, okay. Okay.
I think it's helpful because I'm not saying you have to be autistic to do the work, but my
Okay.
experience of autistic people is usually we have an open heart. Nobody thinks we're Machiavellian. And so I think people can discern that I'm genuine. And I use a lot of humor.
Mhm.
So I think what you're really saying to Elliot is that you do put a great emphasis on therapeutic alliance, just not in the conventional way where you take 6 months to develop
Yeah,
it.
right.
You're just very,
Exactly so.
very super attuned and fully present. I relate to the experience that you're describing, which is the ability to really feel with the client as the client is feeling. Like
Exactly.
fascinating uh, expression of, what did you say? Spraying. They spray it out. It feels like they sprayed you with their emotion or something like that.
Well, it's not a metaphor. I actually feel a wave when the energy releases. I
Okay.
don't think it's a metaphor, but yeah.
Okay. Let's take a question from tape. Go ahead.
Hi.
Hi.
My question is, I hear your depth and how you went really deep in your modality, but I just find being a newer, I mean, I've been doing this over 10, 12 years, but with all the new modalities, IFS, psychedelic, breath work, I tend to get, swayed. And so the result is I don't go as deep in like EMDR or whatever that I was later trained in. So I'm wondering how we can avoid, like, learn from other modalities, but avoid getting sidetracked.
Well, I can tell you that for me, EMDR is the primary thing. Although I couldn't do it without ego state work. Well, see, I can't answer your question because I keep thinking of how I also need somatic and I also need the early trauma approach. I guess my only answer for you is I haven't felt it was necessary to learn more than the modalities that I've mentioned, although I'm also trained in hypnosis, but I don't need psychedelics. I don't know. There's stuff I don't need. And maybe it's because I'm 71, I don't want to learn anymore, but I can do most everything I want to do with the modalities I've mentioned. And that the thing I think is important to have a theoretical rationale for how and why and when we're integrating things, because that organizes it. And that's why I did the NEST approach, because it systematizes. It says at the time of intake, you are looking to see, does this person need standard EMDR or the early trauma EMDR? Does this person need ego state therapy because they're structurally dissociative, or do they need naltrexone because they're alexithymic and somatically dissociative? And then you go down these different decision trees based on what you get at intake and treatment planning time. So that's what the NEST approach is. I can't comment on all the things I haven't learned. How would I? But I don't need any more. I can deal with almost any complex trauma using the ones that I've mentioned. That doesn't mean there aren't other ways, but I would get overwhelmed too. But I would not work without EMDR. It would feel unethical to work without EMDR.
What is the NEST approach when you talk about the NEST approach? I know that that's your approach that you designed.
Thank you.
It's really the systematic combination of several established approaches. Neuroaffective, the N in NEST is for neuroaffective, and that's where affect regulation is addressed. Whether it's, well, whatever, if it's hypoarousal or hyperarousal, there's things to do with neuroaffectively. The E in NEST is for embodiment, so somatic therapy, one way or another. The S in NEST is for engaging the self system through ego state therapy, and the T in NEST stands for both the 8 phases of EMDR therapy and temporal integration, which is the work targeting by time frame, developmental milestone timeframes. So they're all systematically integrated. Oh, I should show you that cartoon if I could ever find it. Probably can't. It's tragic. I can never find what I want. Don't stop talking. I can talk while I'm hunting for cartoons, theoretically.
Somebody's asking how would somebody contact you for therapy?
Go to my website, paulsenpsychology.com, and read the frequently asked questions, make sure it feels comfortable and feels right. All the pricing and everything is there. And register as a client so we can have confidential discussion there. It links to a secure portal. And I can't find what I'm looking for.
Does anybody else have any questions that they'd like to ask or comments?
Yes, when will we have the next training?
When will I have the next training for what?
When will you go for pre-verbal trauma?
Oh, well, I haven't got, the only one that's scheduled right now is in Canada. I'm doing a 4-day NEST training in Edmonton, Canada in November. My workshops are available online on demand. I did find the cartoon I was looking for, but I am happy to go to interesting places to teach. I teach all over the world. Just did Japan and Korea, and I've done lots of places. I'm going to do Chile, Brazil, lots of places. But so if you want to, I'd be happy to come to wherever the heck you are, somewhere in the East Coast, if there's interest. And I got a sister out there I could visit. This is Traumaland. It's like a board game, tongue in cheek. Whoops, you can't see it, can you? But it's very detailed, and it shows if this, then that, if this, then that. It's kind of like chutes and ladders. You know, some people need somatic therapy first before they can do EMDR because they're alexithymic. Some people need ego state therapy first, so you go down this way. Some people need the early trauma approach. You go up the ladder of developmental phases. Some people go straight to regular EMDR for the fiery car crash. That I have
Sandra,
a little Etsy shop.
let's take another question. Shulam, do you have your question? Can you ask?
Yeah, so I'm obsessed with family therapy, and I'm wondering, whenever I hear ego states, I think of family members, and I wonder if you have any thoughts on that, because like getting family members to talk to each other, I find maybe it was even more effective in some ways than having ego states talk to each other if you can get them live, and do it well.
Well,
What
I don't
are
know
your thoughts on
anything.
that?
I don't know anything
Okay.
about actual family therapy. I
Okay.
know that one of my several complaints about IFS is that parts of self are not a family, even though they may have introjected family members. But the goal of a family in the Western world is to get people to grow up and move out. But that's not the goal in a self system, where
Uh-huh.
the idea is to have an integrated self. And so,
Okay. All right.
but certainly internal communication is the very definition of integration, where you're resolving internal conflicts through increasing dialogue. But also parts of self are very often disoriented, even in not a DID person, but a just your garden variety neurotic person. The introjects don't know mom's dead.
I would add to this, and correct me if
Okay.
I'm wrong, but there's a lot more that can go wrong when you're using actual family members. You see, when you're using the projection of ego state work, which you're sort of imagining what the perfect mom or the perfect dad may do, or what I don't know if this is done in ego state work, but you might imagine what your mother would have done to you or for you had she not had the challenges that she did. In other words, what was I worthy of? What if your mom wouldn't have been struggling because her mom was abusive, etc.? How would she have treated you in your imagination? That becomes just very unadulterated, and it's very pure, as opposed to when you bring actual family members. There's a whole lot more of work that needs to go into purifying the responses, that the responses should actually be effective and not sometimes cause more damage
Yeah.
or just be neutral.
I
Am
know
making
in
sense?
3 days, I don't have enough time in 3 days to repair people's internalized parents. I mean, modify their parents' stories in imagination. So that's why we use ideal different parents. And I'm always amazed how few people complain about the idea.
Mhm.
Just kick their parents to the curb in a heartbeat. It's amazing.
Okay. Sandra, is there anything else that we're missing that you want to share with us in these final few minutes?
I just had a thought, but it drained out of my head immediately. Or maybe it's what I just said about 3 days is not enough.
Can we go back to a period in your life that was about 120 seconds ago and see how does that feel? How does that feel for you? And see if we can pull it up.
Well, ego state therapy is a hypnotic intervention. I had the luxury of collaborating for a few years with the father of ego state therapy, John G. Watkins. He was 91 years old at the time. And when I told him what I was doing with the conference room technique, I was the first one to bring the conference room technique to EMDR land, because I heard George Fraser teach it.
Just tell the audience what the conference room technique is.
It's a hypnoprojective method, and that's what I lost. That's the
See, I knew we could.
age regression.
Can I get certified?
Now I forgot what it was again. What did I just say? Oh, it's a hypnoprojective thing where you ask people to imagine a pleasant conference room or gathering place, take a glance in there now, and tell you what, if anything, they see. And if you're in the middle of a deep dive, then what the internal dynamics will manifest somehow in the conference room, unless it's boarded up because they're DID. If you say it from a cold start, the room might be empty. But then if you later on in the session, if you're into something deep and you have them glance into the conference room, it'll be somehow peopled or otherwise represented. And then you can give voice to whatever manifests in the conference room. And when I told Jack Watkins about that, he said, "Oh yeah, that's hypnoprojective." And he taught hypnosis to the teachers of hypnosis who taught the current teachers of hypnosis.
Hypnosis. Grand teacher. Or the great grand teacher.
Yeah. So
okay. Any final questions or comments from the audience or from you, Sandra? Now's your chance. You can reach out and touch Sandra while we have her. Okay. Sandra,
Well, I have a quick question.
okay, go ahead.
Do you feel like when a person goes through the ideal of what you take them through, are they still triggered? Are they still like, what does a person at that stage look like?
Well, it depends on how far we get in 3 days. There's nothing magic about 3 days. 3 days is a good number of days for most people to get symptom resolution, or mostly. Although I do require that people have somebody back home just in case we don't finish. I don't want them feeling abandoned if abandonment is their issue. So, what was your question? Oh, what does it look like? Oh, yeah, most people have considerable relief from their symptoms. That's the whole point. It's not an intellectual exercise. We are metabolizing trauma and replacing it. And people commonly report much greater levels of satisfaction and relaxation and relief and freedom and self-acceptance. So, and I do have one last thing I want to say. I totally forgot about it. My latest book is available in 2 versions. It's called The Beauty and Burden of Autism. There's a full color version that has it and big print. It's intended for use with clients. And then there's also, where is it? A black and white version that's much cheaper, but not as much fun as the color version, but it's got the same cartoons, same book.
Amazing. Okay, well, thank you, Dr. Sandra Paulsen of Washington State, in the forest, in the jungle. I think you described it as. We're like, okay, and thanks for doing this for us and gracing us with your presence and humor. And you're obviously so engaging. It must be so much fun to be at a training with you.
Oh, thank you so much. Thank you for having me. I've enjoyed it very much.
Great. And we're going to stop the recording.